Hello and welcome to PulseCheck with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're going to dig into heart blocks. As always, let's start with our NCLEX style question to get your brain warmed up. Keep what you think the answer might be tucked away, and we'll circle back to the correct answer at the end. A client post-myocardial infarction develops a rhythm with more P waves than QRS complexes, a ventricular rate of 30 per minute with wide QRS complexes, hypotension, and dizziness. Which action should the nurse take first? We have A, apply transcutaneous pacing pads and prepare for emergent pacing. B, administer IV atropine, 0.5 milligrams per protocol. C, increase the oxygen to 6 liters via nasal cannula. Or D, obtain a 12-lead ECG to further evaluate the rhythm. Like I said, hold your answer. We will circle back to it at the end. But first, let's dive into heart blocks. And to do that, really, we need to zoom in on what normal looks like so that we can understand abnormal. Basically, I want you to picture the heart's electrical system as a highway with very specific exits. At the top in the right atrium, you've got your first exit. That is the SA node or the sinoatrial node, basically our natural pacemaker. It's like the DJ that's going to set the beat. It's firing off impulses normally between 60 and 100 times per minute. And that impulse spreads across the atria. So it's going to cause those atria to contract, therefore pushing blood forward into the ventricles. And when we look at an ECG, this is what we see as our P wave when we have that atrial depolarization. All right, so that's a first exit in this electrical highway. SA node, natural pacemaker, 60 to 100 per minute. That's depolarizing the atria, causing our P wave. Got it? Now let's move on to our next exit. From there, we're going to the AV node, atrioventricular node. So obviously it is sitting between the atria and the ventricles. So it's not the DJ, it's more like the bouncer at the club door because it pauses the impulse just long enough for those ventricles to finish filling up. And that tiny little delay is going to be your PR interval on the ECG. After we get the green light from our bouncer, the AV node, that signal will shoot down to the next exit on our highway here. It'll go down to the bundle of His and split into the right and left bundle branches, then spreading into the Purkinje fibers. From the Purkinje fibers is where we will have ventricular depolarization and therefore contraction. And when the ventricles depolarize, that is our big QRS complex. Okay, so we'll go through those exits one more time. We've got SA node up at the top, then we've got our AV node where we're going to pause, see that PR interval. From there, it'll go down to the bundle of His, split into the right and left bundle branches, up the Purkinje fibers, where we then get that ventricular depolarization, causing our QRS complex. And, this is a lot of moving pieces. In a perfect world, the timing is very specific. We get a P wave for the atrial depolarization, and that's followed by a QRS for the ventricular depolarization. That PR interval where we said, hold up, wait a second at that AV node. It's consistent. It's the same length, usually like 0.12 to 0.2 seconds. So everything is in a nice coordinated relationship. It is like a beautifully choreographed dance routine. The atrial lead, boom, P wave. We get a little pause, PR interval. Then we get that big QRS complex when the ventricles contract. That makes good cardiac output. That pushes blood forward. We get good perfusion out to the body. We are happy. Okay, that's normal. Let's get into when it's not normal. Heart block happens when we got a blockage somewhere at one of those exits on our electrical highway. Something happens in that AV node where that bouncer between the atria and the ventricles, it gets sticky, it gets slow, or maybe it gets slammed completely shut and we're not letting anybody in the door. The problem is not that the heart is not firing. The SA node has not stopped firing. So usually the atria are still doing their thing. The problem is we have a blockage getting the message from the atria down to the ventricles. It is all about either a slow, a delayed, or complete failure of conduction through that second exit, the AV node. We've got a few different ways this can happen, and we kind of classify it by degree. Okay, first degree AV block. This is the most mild. This is when it is just slowed down. Every impulse eventually does get through, but it takes longer than normal. So if we have a longer pause than normal at that AV node, we have a prolonged PR interval, and that's going to be greater than 0.2 seconds. But every P wave still has a QRS, so functionally, the dance is still happening. We are just a little sluggish, and this does not usually tank cardiac output. It can be seen in athletes, people on beta blockers, post-MI. It is going to be the most common and the least problematic of our heart blocks. Now let's step it up a notch. Let's look at second degree. Things are going to get a little spicier here. In second degree heart block, some impulses make it through and some don't. So this is like the sticky delay in our second highway exit, that AV node. The atria, again, they're still doing their thing. SA node is fine. The DJ is setting the beat. The atria are contracting. But not every atrial beat gets through that AV node. So we start to develop a drop in QRS complexes, meaning we don't have a P wave for every QRS. Now, we have two types of that second degree heart block, just to make it, a little more interesting for it. The first one is called Mobitz type 1, or you might hear this. I like this. This one's better. This is kind of fun. Wenckebach. Wenckebach is the same as Mobitz type 1. That's our first type of second degree heart block. And that's where basically the AV node is getting progressively more tired. So we get the PR interval, might be pretty much normal. Then it gets a little longer, then a little longer, then a little longer. And then boom, we have a dropped beat. When I say we have a dropped beat, that means we have a P wave and no QRS is following it. The atria have contracted and the ventricles have not. So we've kind of missed a beat in our little dance here. We got blood down into the ventricles, but then they didn't contract and send it out to the body. That's not good. So what you hear people say a lot of times is that longer drop, then you have a Wenckebach. Wenckebach type 1, it's that first type of second degree heart block. The AV node gets more and more tired until we drop a beat, and then it starts over. Now, in real life, this, more rare than type 1, this is not immediately life-threatening. Oftentimes, this rhythm is transient, and we're still getting pretty good cardiac output because the ventricles have decent backup. Like, they're still firing when we have longer PR intervals. We just miss one occasionally with that drop where we have a P and don't follow it up with a QRS. So moving on, that was Mobitz type 1, Wenckebach. Now, what about Mobitz type 2? This one gets even spicier here, okay? The PR intervals of the conducted beats are constant and normal or near normal, but suddenly, out of nowhere, we just have that dropped beat where an impulse never makes it through. There's no warning like in Mobitz type 1 where the PR interval got longer, and then we had a drop. We just had a heart chugging along, normal PR, and then boom, all of a sudden something doesn't work. We get stuck and a signal doesn't make it through that AV node. So this pattern tells us the block is a little bit lower in the conduction system, actually down in that His-Purkinje system. which honestly is a little nastier because the lower the conduction pathway is, the more fragile and the more I get worried about cardiac output. Mobitz II can definitely deteriorate faster than I worry about Mobitz I or especially first degree heart block. It can deteriorate into a complete heart block or even asystole. Obviously, we don't want that. But speaking of complete heart block, that is what we call third degree. So we had first degree, then we had a couple different types of second degree, Mobitz I, Mobitz II. Now with third degree heart block, we also call that complete heart block. And this is where we have a full on breakup between the atria and the ventricles. Okay. They are literally divorced. They are just doing their own thing, completely independent of each other. SA node firing, atria depolarizing. We're getting our P waves. They're marching on across our little strip. But none of those impulses are making it through the AV node, getting to the ventricles. So at first we had slow conduction, then we had conduction that got kind of stuck. In type 3, we are totally stopped. The door is closed and blocked. The ventricles are desperate for any kind of rhythm, so they just fire off their own escape beats. This is either from like a really junctional focus or a ventricular focus. But what you're going to want to know in real life when you're in the room with your client or when you're taking an NCLEX question is that the key between, or the key to figure out this is a third degree, is that the P waves and the QRS complexes are totally separate. They are both marching out to the beat of their own drum. They are not connected because we don't have that conduction passing through the AV node and coordinating this dance. There is no consistent relationship between the P wave and the QRS complex. And when that happens, you guys, this whole dance is for cardiac output. So when they ain't talking to each other, cardiac output is going to plummet. The ventricles are beating way too slowly to maintain adequate perfusion. And if the escape rhythm is ventricular and super slow, then our organs are going to start complaining pretty darn fast. The brain is going to be like, I need oxygen, and you'll get dizzy, syncope, confusion. Kidneys, they don't have blood flow. We're going to drop our urine output. The skin, great place to look for cardiac output. We're going to be cool, clammy, pale, delayed cap refill. This is a hemodynamic emergency. Atria, ventricles not talking to each other, no cardiac output, blood's not getting to the body, and we start shutting down fast. So let's kind of bring this to life with a scenario. Let's talk through a case here where you are the nurse on a cardiac step-down unit. You've got a 76-year-old male with an inferior wall MI. He came in the middle of the night before you had your shift, and he had those classic MI symptoms: crushing chest pain, nausea, vomiting, sweating. He got thrombolytics at a smaller hospital before he was transferred in to us at a larger medical center. So you're coming in as the day shift nurse. He's tired, but he's stable. He's joking with you. Says he's ready to get home and get back to his dog. But you look at his telestrip, you look at that telemetry reading and see it is in sinus rhythm with a prolonged PR interval. Okay, so pause. We got sinus rhythm, we got a P for every QRS, but that PR interval is long. It is greater than 0.2. What type of heart block is that? A prolonged PR interval. That means we have delayed conduction through the AV node. It's slow. Is that type 1, type 2, type 3, Mobitz I, Mobitz II? If you said type 1, you got it. Type 1, or I should say first degree, not really type 1, first degree heart block here is where we have that slow conduction through the AV node. So signals are still getting through. We're still doing our dance. We got a P for every QRS. It's just a longer PR interval. So that is not shocking after an MI. This would be a pretty expected finding on our 76-year-old male here post MI. Okay, so let's continue on with our shift. As the day goes on, you're keeping an eye, and that telemetry starts to shift. That PR interval's changing a little bit. Every beat gets a little longer, or I should say every PR interval gets a little bit longer. We have a longer PR, a longer PR, a longer PR, and then all of a sudden you have a P wave that does not have a QRS following it, and then the pattern restarts. Now, what type of heart block have we progressed to? We no longer have just a long PR. That PR is getting tired, it's stretching out, and then a conduction is not going through. This is second degree, and if you remember specifically, it's Mobitz type 1, where we have that longer drop. The other name for that is Wenckebach. So you want to go ahead and notify the provider of this. This is a change, and it's not a change in the right direction. I don't expect to see a deterioration in that conduction, and it means something else is going on here. We need to monitor closely. In this case study, your client is not yet symptomatic. His blood pressure's okay. His oxygen's okay. His heart rate's fine. He is, for all intents, stable post MI, but we're seeing that his conduction is getting worse. That first degree heart block progressed to a second degree heart block. So you do need to notify and monitor closely. What can it progress to next? So early afternoon, let's say you're at the nurse's station, we start alarming for bradycardia, heart rate in the 30s. We're going to go in there very quickly and reassess. Here is your reassessment of this 76-year-old male. Pale, sweaty, gripping the side of the bed. He tells you he feels like he's going to pass out. And whereas his blood pressure was fine, earlier in the day with that second degree heart block, now it's 80s over 40s. And he looks like it. Pale, sweaty, he is not looking good. What do you think the strip looks like now? Based on the heart blocks we've talked about, where we know that this can go, what could this be progressing to? Hemodynamically, I'm kind of worried that we're moving in to third degree heart block. So if we look at the strip, we're going to have P waves marching out at a steady rate. Maybe that's about 80 to 90. But then the QRS complexes, they're going to be totally unrelated to the P waves. The ventricular rate might be more so in the low 30s, and that's what our monitor was picking up on, and alarming bradycardia. No consistent PR interval. Sometimes a P wave is going to be, near the QRS, sometimes in the middle, sometimes after. There is literally no relationship between the Ps and the QRSs. They're doing their own dance. So this is complete heart block. This is third degree heart block. Remember, same thing, different name. And this is an emergency, okay? This does not support cardiac output. We cannot get enough perfusion. And that's going to explain the signs and symptoms that we are seeing, right? He's hypotensive, he's dizzy, cool, clammy. All those things should right off the bat be setting off your alarm bells. Hey, something is up here. We are not getting good perfusion. You're going to want to look at that urine output to see if the kidneys are being perfused. You're going to want to do a neuro exam, at least briefly kind of check level of consciousness. This client told you he was dizzy, so that tracks with that. And your priority is going to be patient safety. So stay at the bedside and go ahead and call for help. I, in this case, would call a rapid response because we have a potentially lethal arrhythmia with that third degree heart block and a client who is hemodynamically unstable. It is not safe for me to leave the bedside. We're going to stay there. We're going to call for help. I'm going to hit that button, get my rapid response team in there. So what are they going to do in this case? How are we going to fix third degree heart block? Well, first, we need to make sure that we do everything we can to stabilize this client. So we're going to up that oxygen. We're going to make sure that he's laying flat so that we maximize the blood going to his brain. We're going to make sure his leads are on and really get, everything set up equipment-wise. We want to get that defibrillator and put on transcutaneous pacing pads because incomplete heart block, we cannot count on medications to fix things. Atropine sometimes helps with blocks at the AV level if you were kind of thinking maybe atropine for an antiarrhythmic. But once we have a block down below and that his Purkinje system, we're closer to the ventricles now, that atropine is often very ineffective. He is hemodynamically unstable, so we need to pace him. His heart is not pacing itself. We're not getting that electricity where it needs to go. So now is my job to get that electricity on board. We have to pace third-degree heart block, okay? Providers can come in. They're going to assess that rhythm. We're going to start pacing. As we pace, those QRX complexes will be able to be captured, and that blood pressure should come up very quickly. Because once you're squeezing those ventricles, you're moving that blood forward, and you're getting that perfusion. Color should get better. He should feel, less dizzy. Mentition should be better. If his urine output had dropped, that should come back up. All of those sorts of things, this is one of the cool things I really like, because the problem is, even though very scary, quite straightforward. We are not getting electricity to our ventricles. They can't contract, and therefore they can't send blood forward. So I'm going to use electricity to make those ventricles contract, and boom, I have fixed the perfusion. Well, I say I have fixed it in the very short term, right? Like, that's our emergency response where we do our transcutaneous pacing. We're not like sending them home with transcutaneous pacing, you're good as new. That's obviously not the case. In this case, we are going to place a permanent pacemaker because the conduction system was damaged in the myocardial infarction in that heart attack. It was not going to magically fix itself. We had to place that pacemaker to send that electricity out to the heart itself, okay? Now, that is usually not the case with a first degree or even a second degree type 1, that Mobitz I. With Mobitz II, sometimes, but with third degree, that complete heart block, we are gonna need a pacemaker, okay? With all that being said, it brings us back to the practice question I posed to you at the beginning. So I'm going to remind you what that was. Hopefully now you can get to the right answer and understand why. We have a client post-MI that develops a rhythm with more P waves than QRS complexes, ventricular rate of 30 with wide QRS, and hypotension and dizziness. Which action should the nurse take first? A, applying transcutaneous pacing pads and preparing for emergent pacing. B, administering IV atropine, 0.5 milligram per protocol. C, increasing oxygen to 6 liters via nasal cannula. Or D, obtaining a 12-lead ECG to further evaluate the rhythm. So think through. First, evaluate the stem there and say, what type of rhythm is this? What type of heart block? Is it slow? Is it sticky? Is it stuck? It's stuck, right? The P's and the Q's aren't talking to each other. And our client's hemodynamically unstable. They're hypotensive and dizzy. So this tells me I have a third degree that is a lethal rhythm. And if that electricity is stuck, I need to use electricity to make those ventricles contract. That's why A, apply transcutaneous pacing pads, is the correct action. He is symptomatic. He has third degree, complete heart block. Immediate pacing is needed to restore cardiac output. Atropine might sound nice. That might be used for some bradycardias. It's going to be ineffective in a complete heart block. Increasing the oxygen, not necessarily the wrong thing to do. I bumped up the oxygen in our case study. It's going to help support the client, but it won't fix their underlying perfusion problem. The only thing that does that is pacing. And getting a 12 lead, it might help us get more information, but we already know he's unstable. And when in distress, we don't assess. We don't do further diagnostics that then delay life-saving treatment. And in the case of a third degree heart block, transcutaneous pacing is life-saving. That's your key takeaway. I want you to carry out into your practice and NCLEX when you think about heart blocks. If they are symptomatic, if they've got a complete heart block, your priority is pacing. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to PulseCheck with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.